Hello everyone, my name is Siri Tellier and I'm an external lecturer at the Copenhagen School of Global Health. In the last few years, we've seen a rather unprecedented situation with respect to displaced populations, and this poses major challenges for healthcare. Let me begin with some definitions. The Office of the UN High Commissioner for Refugees, or UNHCR, was created in 1950 in response to the large numbers of refugees after the Second World War. And the 1951 Refugee Convention defines a refugee as any person who, owing to a well-founded fear of being persecuted for reasons of race, religion, nationality, membership of a particular social group or political opinion, is outside the country of his nationality and is unable to, or, owing to such fear, is unwilling to avail himself of the protection of that country. Internally displaced persons, or IDPs, have been defined as persons or groups of persons who have been forced or obliged to flee or to leave their homes or places of habitual residence, in particular as a result of or in order to avoid the effects of armed conflict, situations of generalized violence, violations of human rights, or human-made disasters, and who have not crossed an international recognized state border. This definition of IDPs is fairly recent, from 1998. There's no binding international convention and no special UN agency tasked with their protection. And whereas the definition of IDPs is quite broad, here we will concern ourselves specifically with those displaced by conflict or violence. The difference, of course, is that refugees have crossed the border and IDPs remain in their own countries. With respect to trends and levels, data for refugees have been available for decades. However, it's only fairly recently that numbers have been estimated for IDPs, and the numbers remain fairly difficult to collect, including because it is difficult to define and count IDPs. Estimates are that the number of refugees was fairly stable over the first decade of the century, but since 2012 there's been a marked increase. For IDPs, the number increased modestly until 2011, but here again the numbers have increased greatly since 2012. There are many reasons that the health situation of displaced populations is of particular concern. Such populations face increased risk from poor housing, lack of access to food, water and sanitation, crowding, exhaustion, loss of the protective structures of families or communities, language barriers, or the very violence which forced the displacement in the first place, as well as violent or dangerous environments once they arrive. These are some of the factors which may increase morbidity and mortality. Displaced persons may also be afraid to access health services, especially while they're fleeing, for fear that they may lose contact with their family, and they may have left behind some of the things that help them cope with illness or disability, including mobility aids. In public health, we often hear reference to groups 1, 2, and 3 causes of mortality and morbidity. The first group refers to communicable disease, nutritional disorders, reproductive health issues. The second group refers to non-communicable diseases such as cancer, heart disease, mental illness. And the third refers to injury, whether due to accidents or intentional. Globally, we have gone through an epidemiologic transition where from group 1 was the biggest to group 2, and nowadays around 65% of all deaths globally are due to non-communicable diseases. Mortality has declined dramatically on a global basis. Life expectancy has increased from less than 50 years in 1950 to over 70 years. That's fantastic progress. However, in displaced populations, all the risk factors which I just mentioned may cause a reversal of these advances at the same time as health systems may have been destroyed. Historically, mortality rates for refugee populations have been observed to increase up to 30 to 50 times the baseline levels, especially in the first months after displacement. That's a major increase. And the risk factors relate to each of the disease groups that I've just been mentioning. Communicable diseases thrive in overcrowded urban environments with poor water and sanitation. Epidemics and starvation particularly affect young children. In recent years, displaced populations are increasingly from middle and high-income countries. The populations concerned are more urban and somewhat older than in low-income countries. Therefore, the disease patterns of the displaced people are shifting, with chronic diseases such as diabetes, cardiovascular disease, and cancer occupying a larger part of their burden of disease. When populations are displaced, their treatment is interrupted if they have chronic diseases. This may be exacerbated by unhealthy lifestyles accessible in urban areas and taken up in the course of settling in cities. Injury due to violence, traffic accidents, and unsafe working and living conditions may also increase, causing increased morbidity and mortality. Together, this increase in risk factors has been called a triple burden of disease for displaced populations. If we look at the response to this situation, the 1951 Refugee Convention states that refugees should enjoy access to health services equivalent to that of the host population. Depending on the situation, priorities for the early months of an emergency are often measles vaccination, control of other communicable diseases, water and sanitation, surveillance, and reproductive health. Later on, as the situation stabilizes, services are broadened and more integrated with local systems. Health services to respond to chronic conditions, such as the non-communicable diseases mentioned above, are only beginning to be addressed. This is both because it is a relatively new situation and because treatment may be more demanding. Cancer or even diabetes patients may need chronic treatment, which may be complex and expensive, much more so than organizing a measles vaccination campaign. There is a good deal of evidence indicating that populations which are refugees, having crossed a border and come under the protection of UNHCR, for example, or others, often have better mortality levels than those who have remained in their country. And the ones with the worst situation often seems to be IDPs. As you can see from this slide, it's not always the case, but in countries such as Congo, Angola, or Liberia, the IDPs have very high mortality levels, much higher than other parts of the populations. Displacement is often related to what is sometimes called fragile states. The World Bank estimates that about 1.5 billion people are living in situations which may be called fragile situations. And implicit in this definition is that health systems have broken down or are not reaching parts of the population, and not surprisingly, this has implications for day-to-day care of populations and also for progress on such issue as disease eradication. For example, in 2014, the number of polio cases worldwide had been greatly reduced thanks to vaccination campaigns. Only a few countries had more than a couple of cases, including Nigeria, Afghanistan, and Pakistan, with one of the challenges being that polio workers had been targeted and killed. However, polio made a surprise resurgence in Syria as the conflict escalated. Epidemics can also contribute to making health systems less well-functioning. For example, in Guinea, there was a steep drop in attendance at maternity clinics while Ebola was raging. On the other hand, the strong polio surveillance system in place in Nigeria helped contain the Ebola epidemic in that country. There are also many theories that both Ebola and before that HIV/AIDS began to become epidemics, partially due to higher mobility of populations. Thus, there are many complex interrelationships between health systems, and the conditions which force population to be displaced. So this marks the end of this short presentation about the health of refugees and internally displaced persons. Thank you very much for your attention.